Good morning, everybody, or at least good morning in Europe, and probably good afternoon in other parts of the world. My name is Hugo Vinhas. I'm an interventional cardiologist in Faros Hospital in Algarve, Portugal. I will be your chairman in this webinar, Mastering Complex PCI in real-world practice, where we can have the opportunity to discuss about devices, discuss about strategies and techniques. I'm head of interventional cardiologist and leader of the SHIP program in our hospital, and I have also some work in protection, radiation protection as proctor. I would like to, sorry, to advance the slides. Okay. I'm pleased to have Dr.Wenzheng as co-chairman and commentator. Dr.Wenzheng is director of cardiovascular department at Shanghai Chest Hospital, and also will present the guest speakers, Dr.Kamal Chitkara from Royal Derby Hospital, where he's interventional cardiologist and research lead. And I'm very excited to hear about its topic. Then we will have Dr.Jurij Gregoric from Slovenia, Hospital of Izola. Is a famous interventional cardiologist and founder of the Cath Lab of the Future. Is a series of events where he joined different and very, very experienced operators in the topic of complex PCI and CTOs. Very interesting, and congratulations for that initiative. We will have also from Italy, Dr. Stefano Nava from Grand Hospital Metropolitan Nigarda and Clinica San Carlo, where he is also study coordinator and for national, international trials and registries. And finally, we will have the opportunity to hear Dr. Mehmet Erdoğan from Ankara, Turkey. So without more delays, I would like also to, I would also to thank to Brosmed for the opportunity to be here, and congratulate also the company for the excellence of their products. Most of them being part of my daily tools for complex PCI. So without more delays, I will ask Dr. Kamal Chitkara to talk about its topic, Taming the Conundrum. Please, Dr. Kamal.
Yeah. Can you see my slide, or let me just share it?
Need to share.
Can you see it now, the screen?
Yeah.
Yeah, so thank you for the invite. So first patient is 81-year-old lady who is normally quite fit and active. With background of high hypertension, she had stent fitted back in 2007. I could not get any information because the records are nearly 20 years old, PCI. So it was difficult to get anything. All I knew was that possibly she had one stent fitted. So I saw her in clinic and she was experiencing significant chest tightness on exertion, and symptoms were quite similar to 2007 when she had stent fitted. So, so I added on more medications to her. Isosorbate was increased, amlodipine was increased, and she was already on clopidogrel, ramipril, statins, and bisoprolol. But despite this, she was experiencing chest pain and she was giving quite a good history. So I booked her for coronary angiogram. She had an echocardiogram which showed only mild left ventricular hypertrophy, otherwise normal function, and only mild valvular heart disease. So procedure-wise, I took a 6 French right radial artery access. Imaging access was taken with the TIC catheter. I'll show you the images now. So as you can see, there is a severe instant restenosis in the LED. But overall, if I say that 2007 this PCI was done, she has done very well for last 20 years with only moderate to severe instant restenosis, but it's not occluded, and the rest of the vessels seem okay. There is diffuse disease in the diagonal branch. So I proceeded to, after taking all the pictures. Any questions on that?
No?
She's got diffuse right coronary artery disease, which was for medical treatment. So I decided to do PCI. EBU3 guide catheter was used, and circumflex was wired for better guide catheter support. A cyan blue was crossed and placed distally in the LED. So I did the IVUS study first, which showed, let me just show you the images from the IVUS. I don't have live image, but it showed severe ISR. You can't clearly see the stent because the stent and endothelialized, but the plaque burden was significant with severe ISR. So thereafter, I took a RevoEdge balloon, and that's the RevoEdge where you can see the 3 markers. That is a 3 by 10 millimeter, and that you see the expansion. Gave pretty good expansion with this balloon, and I was quite pleased with that. Normally, otherwise, I would have done either shockwave or I would have done NC balloons. And I know that these kind of instant restenosis, normally you end up having multiple ballooning before you actually get good position. So I was quite pleased with that. That's such an old stent with significant ISR, and RevoEdge has redilated very nicely. So once this RevoEdge balloon was done in all full segment of the LED stent, that was the after RevoEdge redilatation. Any questions on that? Is everybody happy with this result before and
Yeah, it
after?
thanks.
Yeah, so I think it is given only there is a distal edge, there is a short stenosis there. So I thought if I do more ballooning, there's a possible that you can get a distal edge dissection. So I decided to put a short stent there, which is a 2.5 by 12 millimeter stent to cover that, and then it will give me more room to post dilate the whole length. So once that's done, then I've taken this is post dilatation with the same stent balloon, and now this is the NC balloon. This is a 3 by 20 NC. And then I repeated the IVUS and still showed quite significant plaque burden with ISR. This time I went with a 3.5. This was a 3.5 millimeter vessel, but the distal was not more than 3. So I didn't want to put too much of ballooning to the distal segment, but this is 3.5 by 20 NC millimeter balloon. And that's the end result that procedure was uncomplicated, became quite straightforward using this RevoEdge balloon. Took me 15-20 minutes and I'd finished the case. Any comments on that?
Yeah, Dr. Kamal, do you think
Yeah.
based on based on the fact that you have a stent restenosis,
Yeah.
would be an alternative to you instead of putting another stent distally using a DCB after this very well preparation you could have with RevoEdge balloon?
Yeah, I mean, I use a lot of drug-eluting balloons to distal segment or smaller branches. But the question is that I was going to, because the vessel size was quite big, and my concern was if I go with 3.5 or something, then I will have a distalized dissection because the vessel size on the
Okay.
IVUS was 3.5. And I was concerned
Okay.
with that. I opened that, it will have a problem. So I
Okay.
thought I'll cover it before I post dilate.
Very nice result.
Yeah. So I think I use a lot this RevoEdge. I think with this nitinol thing, I'm sure you'll talk about it later, but this product has given me quite good way. Like instead of using cutting balloons and shockwave, you just put deliverability is excellent, and you put the balloon in, you get good position, and that's what we're looking for. Simplify the case.
Yeah. We will have opportunity to talk about this device in a more dedicated discussion later.
Yeah. I'll show you a second case. Let me just.
Excuse me?
Can,
Yeah.
Excuse me? Dr.
Tell me.
Chitkara?
Yeah.
Yeah, I have a question about this case because I think this patient is angina, unstable angina patient, right? The
That's
first patient.
Yeah. Yes.
So I see the angiography in the left coronary and the right coronary, and I think the mid part of the RCA is also very significant.
It is very
in standard
diffusely
assays.
diseased. Yeah.
Yeah, and then very diffuse. Why don't you just treat the lesion in the LAD but not in
In
the
my
middle of
practice,
the RCA?
in my practice, I'll bring the patient back and reevaluate the symptoms. If she's angina free, then I'll continue with medical treatment. But if she comes back that she's still getting symptoms, then obviously it's a very tortuous right coronary artery, which can be very complex for her and with her age. So my first preference will be medications. If that fails, then yes, I'll bring her back for PCI to the right.
Okay. Did you have any evidence in the ECG or
No, ECG, there were no changes.
ECT to guide you to choose the vessel you treat? No evidence.
There were no ECG changes. ECG is normal
Okay.
sinus rhythm otherwise. I went with the PCR to ISR because I think the LED is more prognostic, and this was the most likely causing the ischemic burden. She has been seen in the clinic, and she's angina free at present, but we'll keep an eye. If she comes back, then yes, right can be done, but I think all her symptoms were due to LED.
Okay, thank you.
Okay, I'll show you this second case. This is show you a slide first.
Yeah, Dr. Kamal, could you present in the PowerPoint presentation mode?
Yeah, okay, 1 second.
Yeah, perfect. Yeah.
Can you see it now?
No. Okay, so yeah. Okay, you can
So
go
this
on.
is
Yeah.
So it's the 81-year-old chap who came with inferior acceleration MI with acceleration in the inferior lateral leads. Procedure was done by my colleague, and I'll just show you the images. Patient has got severe distal left main stem, severe obtuse marginal stenosis. This is the diagnostic pictures taken before the right coronary artery. So this is done by my colleague. You can see severe calcified LED from top to mid segment. So, and this is the right coronary artery, which was occluded distally with PB1 to 2 flow and severe proximal stenosis. So it's a very tortuous vessel, already looks very complex with this guide catheter engagement. So operator tried to open up with even with a guide liner. He got some flow back. Maybe that's the time he should have started. But I think there was quite a lot of coronary artery dissection. So for basically he failed in getting any equipment down the right coronary artery, and subsequently because of coronary artery dissection, procedure was abandoned. And then the plan was made for case discussion in the MDT. That's the final result. So patient came back in the MDT meeting, and all the angiograms were seen by the surgeons, and the surgical, she was rejected. This patient was rejected. Echocardiogram showed moderate aortic stenosis, and ejection fraction was 35 to 40%. The right area was already infarcted. The basal inferior wall was not pumping. So the plan was made for patient to have PCI to left main stem and LED calcified stenosis. So procedure was done. San French guide cath. There was quite a poor guide cath support, so guideliner were used. I will show you the images. So that's with a guideliner. Started opening with a 2.5 by 12 balloon. It was quite difficult to cross even the intravascular ultrasound, and only up to the mid LED the IVUS was crossed, and which showed quite significant nodular calcium, and MLA size was about 6 millimeter. The second wire was for like a buddy wire, so now we got 3 wires. And this time, this is the IVUS catheter, and after IVUS only up to mid LED for the balloon dilatation. And then with the help of guideliner, a shock wave was delivered, which was a 3 by 12 millimeter into the mid LED. So there's a lot of coronary dissections, and in mid LED, there's a 3 by 23 millimeter stent was deployed, and 3.5 by 33 millimeter stent in the proximal segment. So whole length was post dilated. That is a 3.5 by 15 NC. And then 3.5 by 15 millimeter left main stent was deployed in left main to the LED, which was post dilated with 4.5. As you can see, there's quite a small opposition in the left main stem stent, despite using 4.5 millimeter NC balloon. So then a 5 by 6 pot balloon was used to finish the case. So this is a 6 millimeter 5 by 6. The stent was post dilated in the left main. So this is the end result. Procedure was quite lengthy, and it took about good 2.5 hours to finish the case with a lot of ballooning. Patient was symptomatic with a bit of chest pain and was moving around on the table, wanted this case to be finished. So I decided not to do the obtuse margin on that day. And I think there was quite a lot of procedure was done in the left main to LED, which took 2.5 hours. So if everybody thinks the same, I stopped, and this was the end result. So any comments?
Yeah, Dr. Kamal, This
Yeah.
is a 6 French guideliner, I believe.
It is a 6 French guideline and a 7
6
French
French.
guide, yes.
7 French guide. Okay.
Yeah.
So, yeah. Usually when I need to have 2 wires to protect one vessel, and I need to have a good selective injection or a selective cannulation with the guide liner. It is other possibility to use it. Instead of a 6 French guide liner, is 5.5 that could have a second wire outside of the guide liner in a 7 French guide catheter, instead of
Right.
having 2 wires inside of the guide liner.
Yeah,
And
that's very interesting.
you can have a more deep progression with your guide liner in the vessel you wanted to have more support, active support. Well, it's just a comment.
Okay. No,
I
thank
don't
you.
know
Thanks for that.
if Dr. Wenzheng has comments on this presentation, this clinical case.
Yeah, I think in this patient, I agree with Dr. Hugo that maybe we need to choose a 7 French guiding catheter in this kind of case. In case when some disaster happens, we don't need to change the catheter. The 7
It is a
French is
7
a
French
good
guide.
choice.
It's a
This
7,
is a
yeah,
7
it's a
French?
7.
Okay,
Yeah.
okay. And one more thing is, I'm just wondering, in this kind of case, we can see the very severe calcification. Why don't you just choose rotor blade in this kind of case?
Yeah, when I started,
Because we can see after you pre-dilate the mid part of the RAD, we can see the dissection.
that's correct.
If the lesion is not opened very well, we may not send another balloon into this part to do any more dilate. And in this case, if the dissection happens, we cannot do any more rotor blade. So maybe in this patient, I think, of course, the result is very good, but I think rotor blade may be the best choice in this kind of case.
No, I absolutely agree. Rotablation would have been better. When I picked up the case, I thought I will get away with shockwave to the mid segment, and the rest can be done.
Yeah.
It was the problem was sending all the equipment down, and that's why guideline was helpful. But yes, you're right.
Yeah, thank you. And I have one more question is about the RCA. And we can see when you do the first time procedure, the RCA was caused a very severe dissection in the ostium with the RCA. So you just finished the procedure, right? And to the MDT group.
Yeah, that's correct.
Yeah,
So that case was done a few days before.
Yeah. My question is, I see the wire is already go through the distal part. Why don't you continue the procedure? Finish the procedure.
So patient came with primary
Was the
PCI.
patient what?
I did not do that procedure. Procedure was done by my colleague for primary
Yeah.
PCI. He decided to stop, even though
Oh,
the
he
wires were
decided
there.
to stop.
He decided to stop because he was finding difficult to send any equipment down there. So he decided, and then obviously it was 3 days later, patient had already infarcted with Q waves, and the inferior wall was completely akinetic on the echocardiogram. That's why surgeons decided not to take this patient for bypass surgery and aortic valve replacement. And plan was made to do the left coronary artery and TAVI in future if needed for aortic stenosis.
So before you do the LAD, did you check the angiography of the RCA?
No, I did not know.
Why don't you do that? Because if the RCA is not very good, if something happens when you treat the LAD, maybe the circulation of the patient will be not so good.
Just the
Right.
inferior wall was akinetic, and the right coronary artery was, I think it was all dead territory with previous PCI and myocardial infarction. It wouldn't have altered the management plan.
Okay.
So there is no evidence of viability or ischemia in the right, so choose to treat the left. Okay.
Okay, thank you. To read that.
Thank you, Dr. Kamal. So we'll move forward, and I will ask Dr.Jurij Gregoric to present its topic. Please go ahead.
Hello, do you hear me?
Perfectly.
Nice and well, okay. Thank you very much for Brosmet to inviting me and giving this opportunity to, let's say, share my insights about the one thing I consider really important in nowadays practice in interventional cardiology, and which I focus a lot also in my educational activities. And this is lesion preparation. So let's say, do you see the slides?
Perfectly well.
Okay. So why I call it the revolutionary edge? Because I've been using cutting balloons since the advent also of my interventional cardiology practice, and we always been a little bit frightened. What we are doing. I mean, we are cutting, and cutting into the vessels implies maybe this effect of a word cut. So the word cut means like I do also device therapy. So when you cut the skin, cutting is not something that is really, let's say, seen in a really nice way. And mostly people who wherever I go to teach and proctor, they are like, oh, we're cutting balloons and stuff. I mean, first it gives you fear, and then okay, when you start to use it, then you know that it's not like that. But anyway, the cutting technique has been evolved so much that basically from a world of fear comes into the world of using it in an everyday practice and being really friendly with it. Okay. So from my point of view, the lesion preparation is the cornerstone of modern PCI. We are reducing the plaque burden. We do achieve adequate lesion compliance. We reduce elastic recoil. We facilitate device and stent therapy. We ensure that the stent or device is expand and opposed pretty well. And with this, we improve, of course, precision of the PCI, and with this, the long-term success. And which are the situations that we want to use the cutting balloon? So, of course, historically, in-stent restenosis, fibrotic resistant lesions, calcified lesions, a little bit less with the past cutting balloon, the ostial lesions, side branch preparation in bifurcation lesions, and of course, undilatable lesions before stenting. And when I cut, why the RevoEdge is so innovative and really good from my perspective. It's the second cutting balloon in the generation, and it has these 19-hole blades which are fixed on the distal and proximal parts without a base or glue. Because if you see the Wolverine on the right, the stainless steel blade is embedded, and the adhesive layer it's glued to the balloon surface. So basically, it's way more bulky. And the advantages of 19-hole, the RevoEdge, basically, these cutting blades have higher hardness and better super elasticity to prevent this irreversible deformation and damage to the blood vessels. And it means that they are safer. And they also have lower bending stress than stainless steel and offer some more streamlined cutting design. And you see the blades of the RevoEdge are bigger. So the blades of the Wolverine are 0.13 millimeters and the RevoEdge 0.21. So that means that because of this, that they are fixed into the balloon, the cutting you can see over here is way better. You can see on the top, compared with Wolverine cutting balloon and the scoring balloons that are currently on the market, the main competitor, basically, in terms of being a little bit more similar, but not, is the NSA Alpha, which is like a scoring balloon, has plastic blades, which are not really suitable for cutting. And you see that on the histological pictures and the OCT that the cutting with the RevoEdge on the left is way more pronounced than cutting with the Wolverine. So, and if we see the, let's say, the applications where we can use the RevoEdge with the lower crossing profile, we have also the ungulated lesion treatment. We can go to the tortuous vessels, and of course, a better cutting effect. We do have the third marker on the top, which is 6 millimeters away from the two markers, the proximal marker of the cutting balloon, and that means that you have the visibility of all the catheter, not just the balloon. This is a non-compliant balloon. The Wolverine, as much as people want to think about it, is a semi-compliant balloon. It's not a non-compliant balloon. I mean, here we do have the two layers. We have the inner layer and the outer layer. And so these two layers make a balloon basically go up to 20 atmospheres and being non-compliant. So these robust materials can achieve accurate and safe dilatation under high pressure and effectively reducing the elastic retraction and the dog boning effect. Of course, you know, there is no perfect balloon, but anyway, with all these technical things, we can basically reduce the and make it better. And you know, so there is no NC cutting balloon on the market right now until RevoEdge. And there is also this innovative balloon forming. We have the patent microcrystalline technology for the thin wall. The balloon is wrapped really closely. And because of this, you can see that the tip entrance profile is the same. But, you know, the tip entry profile is basically really not important in balloon crossability. And we do have the folded balloon crossing profile, which is way less. RevoEdge has a lower crossing profile than the Wolverine. And because of this, we have better crossability, and the RevoEdge can be used also in lesions at the angles of more than 45 degrees. And, you know, because of all of this, we can have a way broader way of application that basically, as a, let's say, the other cutting balloon, and we can use it like in DCB preparations, osteal lesions, calcification, as I said, small vessels, instant restenosis, bifurcations, long lesion, and of course also tortuous lesions, which was really unthinkable before RevoEdge came out. So how can we use it? So for less than 3 millimeter vessel, we should use less than 1-to-1 ratio up. You know, for the bigger vessels, we can use 1-to-1 ratio. And if we have the calcified lesions, we should undersize by half. So to make it like 2.5 in a 3 millimeter vessel ratio. We do position it at the lesion and we inflate it a little bit slower up to 4 atmospheres. And then we go 2 atmospheres up every 10 seconds and we hold it at the end for 10 seconds. So the use should be really slow. And if you're good with drug-coated balloons nowadays, which you inflate like for 1 minute, this is somehow similar. Also, because of this, we can get the best effect. Of course, we want to dilate the distal part first, and if we have 2 wires, we need to withdraw the RevoEdge first. Because it's a non-compliant balloon, just take it in consideration. It's not for post-dilatation. You should use it just for lesion preparation. Okay, so now a little bit of cases. So you know all that the cases can be done in the one way or another. And I will show you some cases that basically we did just mainly with RevoEdge. So this is a 52-year-old woman, no STEMI. There's a circ stenosis, simple PCI, and the stent was put in, and there was proximal stenosis propagation proximally. And then we do the IVUS. It was the intramural hematoma at first. And Then we did the RevoEdge. We fenestrated the hematoma 30.10 to 18 atmospheres with a cut ring technique for treatment of flow-limiting intramural hematomas. And on IVUS, you can see here the cut, really nice downside, and smaller hematoma was and intimal tears aided for hematoma drainage. This is another case, 61-year-old man with exertional angina. You can see here the heavy calcified mid-RCA lesion. First, my colleague who started the case did the basically physiology measurements to see if it was important. And of course, it was important, although the RCA shows really strange results while using physiology. And you can see here on the right, we used RevoEdge after some dilatation, and we can see here that it was not really good expanding at first. So, of course, you can see then at the end that the expansion became complete. So the effect of the non-compliant part of the balloon came into effect. And you can see here, we did multiple cuts, the Rodin cut technique in the mid part, in the mid segment. That means that I will talk a little bit more about the Rodin cut technique in the next slide. And this is the final result. Synergy Megatron inside post-dilated to 4.5, and the result was really good. So the Rodin cut technique, this is the technique basically put on paper from my colleague from Belgium. And it implies that when you have a calcified lesion, basically you cut and you rotate. You rotate the cutting balloons because when you cut just once in the same position, you have just one cutting area. But if you have like a circular calcium, and if you want to get rid and not to use any advanced or let's say more expensive tool, the Rodin cut technique is really good. So basically you inflate, you deflate, you rotate a little bit, and you do it like 5 to 15 times. With this, you can achieve really, really good cutting and circumferential cutting in multiple areas. And you can basically also do chiseling. That means that this is like putting some plaque away, not by plaque modification with rotablator or orbital, but also with cutting balloons. So multiple inflations with small rotations, 5 to 15 times. With this, you can achieve way better lumen gain than just with cutting in one position. So this is another case, really hard calcified lesion. We have here an ostial RCA stenosis, and then in the mid part, in my usual setup, this would be like a direct rota, but I choose to do it a little bit different way. So we dilated with many things. So we had recoil after NC balloons and scoring balloons and Naviscore, which is really, let's say, hard and powerful. And then we did a plaque modification with RevoEdge over here. And here you can see the really nice vessel from ostium till the distal part. And we finished the case with implanting just 2 DCBs. Of course, also here I did the Rodin cut technique to dilate on the part at least 5 times in with a different constellation of blades and rotating. This was the toughest case over here. It's a man that I know at least, I think, 15 years. He had the first PCI, I think, like 15 years ago when he was really young. ischemic cardiomyopathy, ejection fraction 30, so like multiple PCIs, then cabbage, then re-PCI after cabbage. As CTO of the RCA, and in June 2024 had an STEMI. It was instant restenosis of the ostial circ. It was done just PCI with dilatation with non-compliant balloons and then DCB. And then this year again, he came back, and you can see over here was a heavy instant restenosis of the native circumflex, which was already stented, like from the ostium of the left main till the mid segment. So you can see here the IVUS of the most, let's say, heavy diseased part. You can see the outline here of the IVUS, so how big the vessel is, and there are some stent struts that can be visible over here. I use the HD IVUS from Inside LifeTech, and the picture is really good. And you can see that it's heavy calcified restenosis, and so hard. So this picture was taken after pre-dilatation because I could not pass with the IVUS over here. So fibrocalcific instant restenosis, very hard to tackle, and so I choose RevoEdge. Again, Rodin cut, multiple inflations, 3.0 to 10. To try to reach optimal expansion with no boning effect. You can see here a little bit of boning effect. And at the end, what we achieved basically with cutting in that area was somehow okay, not perfect, but I don't think that with any other technique we would achieve this effect. Of course, I could rotoblade from the start, but I choose a different approach. Yeah, I was satisfied. I was satisfied, but not so satisfied. So I finished the procedure with the OPN over here at this circumferential calcium, and this is at the ostium. You can see the final result. So the osteal proximal part was okay. The mid segment still not okay. I mean, I would like a better result, but I think this is the most we could get in this situation. So look, the severe instant restenosis, this is IVUS before and after cutting. This is the ostial part. And this is the mid segment, which was the most severely diseased. So we achieved something with RevoEdge that I don't think that it could be achievable with the other cutting balloons. So 82-year-old man with exertional angina, 3-vessel disease with functional CTO of the proximal LED and the severe stenosis of the circ and CTO-RCA. We crossed with Gladius on true cross microcatheter, cross the lesion over here, which was relatively easy. Afterwards, we did plaque modification. So initial pre-dilatation with Alveo 1.0, Sapphire, NC, Sapphire 1, Sapphire NC, which is a really strong non-compliant balloon, and then Scoreflex 2.5, which didn't work really well. And of course, afterwards, again, the Rodin cut technique with RevoEdge 2.5 per 10 millimeter to 18 atmospheres. I think it was 7 or 10 inflation. And so we achieved a relatively good result, relatively good lumen. And this is the final result after 2 DCB into the LED. again, really nice plaque modification. So, and we were able to finish the procedure just with a drug-coated balloon. So, I just put up some cases which I think are different one to another. And so the key features of the balloon makes us have the clinical impact, so the fixing cutting blades, we have the secure distal and proximal fixation without glue, and we have superior trackability, strong, precise cutting, and we have also, because of the one-piece nitinol blades, we have high hardness and super elasticity. So that means that it anchors to tissue, and we have the controlled dilatation, and we have less risk of dissection perforation. I didn't have any dissection or perforation till now with using RevoEdge. So with the dual layer design, this microcrystalline balloon, we do have a non-compliant balloon with RBP up to 20 atmospheres and smaller profiles, which is really good to handle resistant and especially calcified lesion, accurate and safe dilatation, and we do not have a dog bone effect. Although I showed you one picture that I did have some, let's say, wire bias, and the balloon was not expanded in, let's say, excellent way, but it was not so much dog boning, and at the end the balloon expanded. And we have wide configuration range from 1.5 millimeters and up, and lengths from 10 to 20, and we can basically treat diverse lesion types, and we have complete size matrix for flexibility. So the key takeaways: we do have a powerful cutting and high pressure resistance. We do have precision with enhanced safety, and the tool is optimized for complex and calcified lesions. So this is RevoEdge. Once again, thank you, Brosmet, for giving me this opportunity. I hope that many more will use it now, listening to my presentation. So thank you a lot. And
Thank you, Dr.
Thank
Jurij. Well, I think it was congratulations for your brilliant presentation where you could show us important an advantage of the RevoEdge. I must say RevoEdge is one of my favorite device for prep lesions. Nowadays, with DCB increasing use, in myself, I'm doing more than 80% of angioplasty with DCB, and I must say RevoEdge is my top first balloon to prepare. And as you told, it is important not only use it, but how to use it. And this progressive increasing of the pressure, 2 by 2 atmospheres, waiting 10 seconds in each step, it's really, really important. I don't know if it is the progressive increasing or if it is the final inflation. I mean, the global time of inflation of the RevoEdge, but the final result is usually great without huge dissections, as we see frequently with Wolverine. But the preparation result looks really, really nice with intention to a primary angioplasty with the DCB use. That's really, really, really interesting. Thank you also for showing us and teaching us that, and remember the rodding technique, it can be quite useful technique to improve the results with these with the RevoEdge and also the Wolverine. Do you think that with this device, is there well, is there still indication to Wolverine? Because I still use a lot of Wolverine. And it is important also to say that RevoEdge, it's not a scoring balloon, because sometimes people tell me, well, do you have the score RevoEdge? No, I have the cutting RevoEdge, because it's a cutting, it's a nitinol. A nitinol is not a plastic, it's a metallic combination of three substance, and as you show us, it has a cutting effect when properly used. So do you think, what have been your use of Wolverine comparing with the RevoEdge?
To be honest,
Yeah,
I maybe used two Wolverine the past half year to way more RevoEdge. Because the thing is about, so if I want to use Wolverine, then it implies, oh, I need to put a guide extension. Okay, I put it guide extension many times. But anyway, you know, it's like you need to prepare the lesion pretty well before putting it, the Wolverine, because it's really bulky. So my standard of care nowadays is like dilating with a non-compliant balloon, then see how it goes. And then, you know, then to score the lesions, of course. And if there is no effect, there is recall and stuff, then I use cutting. Then this was my setup a little bit earlier. Now I go to cutting way earlier than I did like before RevoEdge, because as I told you, so the scoring balloons were a little bit more attractive, powerful in going through the lesions, and Wolverine was really bulky, and I mean, he's really bulky. I don't say it's not effective, but especially now in calcified lesions, which Wolverine was not that effective, we have to say, because it's a semi-compliant balloon. It's more used in heavy fibrotic tissue. Now I use it in way more, let's say, I don't use Wolverine that much, and I use more the score cut technique with some scoring balloon beforehand. Especially, for example, I do use the Nava score from my vascular, which is not similar to the RevoEdge. Just they confuse the NSA alpha, which is like similar in terms of blades, but those blades are plastic. They don't do
plastic,
anything.
yeah.
You know.
Yeah.
So to score with a powerful balloon, and then to cut, and don't forget, always at the end you put a bigger non-compliant balloon, because you know, with this we can have the effect that we want. So we have the plaque modification, lesion preparation, and luminal gain. If we will have the luminal gain, then we will have also the good PCI, regardless of what we put in. We put in the DCBs or we put in the stents. If we do it correctly in a big vessel, it will be really effective, regardless of what we do.
Yeah. One issue also is using the image, because sometimes when we prepare lesions and there is still some recoil, mainly in fibrotic lesions, my experience, based on my experience, if we have some recoil, important recoil, I mean, with intention to use a DCB, if we do IVOS image, we sometimes we can see that the vessel is bigger than what the luminogram show us. So we can update the size of the cutting to improve this recoil, and well, it's really interesting how the image can help us to upgrade the balloon sizing and to obtain with this correct inflation mode of RevoEdge finally.
I don't hear you now.
We will simply finish the. Sorry. Are you listening?
I didn't hear you for like a sec, for half a minute.
Well, I was saying, are you listening now?
Yeah.
Yeah. So I was telling the importance of image to upgrade the
sure.
sizing of the RevoEdge to overcome some recoil properties of the fibrotic lesions to finish the procedures with the DCB.
Yeah, I mean, is the corners imaging. I didn't talk anything about imaging, but imaging, as you said, is like to size properly, and especially in proximal parts, it's very safe to use intravascular imaging. And also you can check the effect. You know, the Rodinka technique, we check the effect with the IVUS. So basically we could see cuts and different cuts through the calcium wall when we rotate the balloon. So imaging for sizing, especially proximally, a necessity, 100% in the osteoproximal LED. And yeah, I completely agree.
Thank you very much, Jurij. I don't know, Dr. Wenzheng.
Yeah, thank you. Very nice, very nice case. But I did not have chance to use this cutting balloon in our hospital. But I see the cases you presented, and especially in the third case, I see the proximal of the RCA is very tortuosity. And did you use any extension to help the cutting balloon to go through the? No. Oh.
It's torture. Yeah, that's why I have to. So I use the cutting balloon without a guide extension, and that's really I needed then to put.
Yeah.
I needed to put the guide extension to put a drug coated balloon, but not for the RevoEdge.
Not for the cutting balloon, right?
No.
Yeah, that I'm very interested in this case because in our daily procedure in this kind of case, usually the cutting balloon we use cannot pass the proximal part because of the tortuosity of the vessel. So
yeah,
very good. I think this may be a very good device for
yeah,
us
it actually
to use.
is. You know, when I used it for the first time, I was really surprised, and then I called my friend Gregor Leibingut in Switzerland. And I said, Gregor, do you know this device is from a Chinese company, Brosmet, it's called RevoEdge? And he said, yeah, I just tried it last week. I mean, it's fabulous. I said, yeah. So, you know, whenever we try something new, then we call each other. And if you have, nowadays, if I would go into private practice, I would take just 2 balloons with me. 2. I will not tell the first one because it's not your company, but second one is RevoEdge.
Yeah, great. So maybe I need to try this in our case. And then more question is about the pressure. I think in the last 2 pages in your slide, you mean maybe you I don't know what kind of pressure you will inflate the balloon in
1820.
1820. Is that okay? Because in nowadays the cutting balloon we use in our procedure, if we inflate more than 16, when we deflate the balloon, sometimes it's very tight for the balloon to go out.
The deflation was really good, and I used a lot this Rodin cut, and I inflated like 5-10 times, like without any problem in deflation. You see, many balloons have deflation problems, especially. I will not talk about the bad ones, but you know. But this one, I didn't have any deflation problems, and also with multiple use in inflating, deflating. There was no. I had till now any issue. I know that some issues will come for sure with broader usage, because as I said before, there is no perfect for me material on the market, but we can aim to have. If you know a lot of material, you can use it in way different situations, and because we aim for treating the patient. But up till now, the RevoEdge surprised me really, really a lot.
Okay, thank you. I have no more question except
Thank you.
cases.
I have to
Thank
agree.
you.
I used to use a lot of Wolverine balloons and always used to put it in, pull it out because can't deliver. Or then I have to use
Yeah.
a guideline or some other device. It was a
Yeah, sure.
completely nightmare. But since the RevoEdge, the procedure has become so simplified. And as you say, you don't need too many balloons on the shelf now. Just use one or two and keep RevoEdge as a a baseline your NC balloon. What about what do you think of RevoEdge becoming a drug-eluting balloon in future? Do you think there is a possibility of technology there that they can convert into DEB along with cutting?
Yeah, but we've been thinking about this design for some time, how to put the drug effectively into the vessel wall, and maybe with cutting into the wall and then releasing the drug would be, let's say, a novel new technique to make a PCI in the future. We don't know, but maybe this is the way to go.
I think it has a potential and should be explored.
Yeah.
Because you're cutting into the vessel wall, and then if the drug releases to those cutting segment, that's
Yeah,
what we
sure.
want to do.
Yeah. I agree.
Okay. So just comment regarding the pressure. I use a lot of RevoEdge and higher pressure, more than 20 atmospheres, just to see the safety of it is, and I never had any complication or rupture of the balloon.
Good.
So it's really safe, with a great profile. So we are on time, and I think thank you very much for your presentation, Jurij, and your
Thank you.
brilliant cases, complex procedures. I will ask Dr. Stefano Nava from Italy to start his presentation regarding pot use, pot balloon use. Thank you very much.
So good morning, everybody. Thanks for the invitation. I think you can see my slides. So argument of my talk would be the pot, both the technique and the pot balloon, which might be very simple but still educational and has many points of discussion. We all know that we are treating coronaries that are not tubular but tapered. We have in the past, we had many laws and formulas to understand the anatomy, but nowadays with the imaging, we can easily have an idea of the true size of the arteries we are treating. And with this technique, with the pot technique, we adapt the stent to the vessel and not vice versa. And with the use of a short balloon, we can make our stent tapered. And then with the kissing or with the pot side pot, we can also have a good scaffolding of the side branch ostium. And all this seems very easy, but we still could have some problem, because if we do not perform a good pot in terms of sizing, we will leave a stent not opposed. And if we perform a too distal pot, we can have a carinal shift and have troubles with our side branch. And also, without performing a pot, we will for sure have a stent floating in the proximal part of the vessel. We will have troubles in recrossing the side branch, and we could go through some stent struts. And also, without the repot, we can leave an oval shape in the proximal part of the stent. So, and also when we perform a two-stent intervention, we for sure need a final pot to ensure a good result. And I will not show data or studies because I don't want to be boring, but even in very expert group of interventional cardiologists, without using the final pot, we will for sure have an under expansion of the stent in the main vessel, as this study showed. So we need dedicated tools for this part of the procedure, and pot balloon is for sure the best in class, because we can see that we have a device with a very short shoulder, a very small entry and crossing profile, and it's a balloon that is very easily delivered in the proximal part of the stent. We can also recall cases in which we had some troubles advancing a big balloon in the proximal part of the stent. And with this balloon, usually you can easily reach the proximal part of the stent and perform a good dilation. And also we can easily spot the markers, and we can easily recognize where to place our stent. And this balloon for sure had this very short shoulder that no other competitor have, and this really helps us in performing our procedure. It has also a very ultra low profile, and there's no transition, so the crossing is really easy. And it is also a real non-compliant balloon, so even if we go higher with the atmosphere, we do not gain much diameter, and we can perform a very good post-dilation without the dog bone effect. Going through some cases, this is a young man who came to our hospital for an STEMI, and you can see a subocclusive lesion of the proximal LAD, very close to a bifurcation with a big diagonal branch. And usually we perform a lot of imaging in our cath lab, and you can see going proximal to distal, a big proximal LAD, a very diseased LAD before the bifurcation. As always happens in the site of bifurcation, we have some disease also after the takeoff of the side branch, and then we can easily size the distal reference diameter. We implanted a big stent, a Megatron 4, and then we optimized the bifurcation with IVUS, and we went up to 5 of diameter. And in those cases, as previously mentioned, we usually use imaging to check the proximal part of the stent in proximal part of arteries like LAD, so we can achieve a very good stent expansion and apposition. This is a very simple case. This is something more interesting for us. This is a post-CABG patient that came to our attention. You can see that there's a distal left main stenosis. LAD is diffusely diseased, and then in the mid segment is occluded, and also the ramus is occluded, and the patient has also a CTO of the first OM. Our strategy was to treat ramus and LAD and perform an inverted tap. So the patient had mid LAD stenosis, and occlusion afterwards. The graft had a stenosis at the anastomosis site, so we decided to treat also the CPO of LAD, but decided to perform an inverted tap. So we treated first the ramus and then treat LAD, because as you can see, the lesion of the ramus was unstable and acute lesion. So we perform a PCI of the ramus. We implanted first a stent in the ramus, then a stent from the left main to the ramus, and then we perform a pot of the left main with a 4.5 balloon. Then we rewired LAD with a Sion guide wire, and without feeling any resistance or any problem, then we perform, as we sometimes do in order not to push too much in the stent of the left main, we did gentle dilation of the ostium of LAD with a semi-compliant balloon. And then we performed the PCI of LAD, putting a 3.5 stent, and we did a final kissing. And then we checked the result, which seemed to be very good. And this was a procedure performed with the IVUS, and then we did a final IVUS on the guide wire that was from left main towards LAD, and this is what we saw, that this is the stent in the left main. This is the IVUS catheter on the guide wire that goes towards LAD, and we have almost 90 degrees of our left main, which is not covered by the stent struts. And so this is what happened, that we probably did not perform a good pot, and we rewired the LAD through some struts of the left main stent, and with the semi-compliant balloon we did not feel any resistance. We dilate the balloon, and then we put the stent in LAD without feeling any resistance. So we rewired the LAD with a second wire, and then we did a kissing balloon, and the final IVUS showed a very good stent position in the left main. And this was the final result. This is another case that was sent to our hospital from another center. It's an old patient with a severely diseased with LAD with a very calcific subocclusion. In another hospital, they were not able to dilate this lesion, so they sent the patient to surgeons. They did not accept the patient, and they referred to us, as usually happens nowadays. So we approached this patient with imaging. OCT was not crossing that part of LAD. We had a very mixed pattern of calcification, but the microcatheter advanced without many difficulties. So we were confident to treat this patient with orbital atherectomy, and we did not feel we needed rota. And we treated this patient with orbital atherectomy and with the both speeds, both 80 and 120. And then we started dilating the artery with, I would say, good results in terms of gain, the lumen gain. And then we put the first stent, choosing the landing zone according to OCT that would cross after the lesion preparation. And we inflate this 3.0 stent in the mid segment, protecting that diagonal that you can see. Then we did a pot with a 3.5 balloon, and we probably, with the shoulder of the balloon, made a carinal shift, and we occluded the diagonal, whose takeoff probably was with a very short angle, acute angle, and we could not estimate the real takeoff of the vessel. The patient, as usually happens in those cases, starting having chest pain. We had ST elevation, and we failed to cross the vessel with regular MC and Sion and UB3, and we used an angle tip microcatheter with the Sion black. And because when and then when people when things starting going wrong, they go much worse. So we try to dilate the stent towards the diagonal with a semi-compliant balloon, and we have a rupture of the balloon, and we have a distal slow flow, and patient has some hemodynamic impairment, but in the end, the patient did very fine and well, and we achieved a good result. And this is just to say that in this procedure, the simplest part, which was bifurcation, was the one that really affected most of the procedure, rather than treating a very complex lesion of a long lesion of the LAD. As I showed, but it's all about precision, because if we do it too proximal, we could have a proximal edge dissection, and we could not achieve a good scaffolding of the side branch. And also, if we perform it too distal, we may have carina sheath and overstretch the distal vessel. And with this balloon, we can really achieve a good position of the stent before the bifurcation. But also, the distal part of the stent is not something that we can neglect. The distal optimization technique is as well important, because we can have a not good apposition if we are too proximal, or we could have an overstretch and also distal edge dissection. And we can see that if we are too distal, we might have an overstretch and edge dissection, while if we are too proximal, we can leave a part of the vessel which is not well expanded and opposed. And this is the last case I present you, is what we call a fellow PCI. We have our center is a university center, so we have fellows. This patient came to our hospital with chest pain. Our fellow performed the PCI with after pre-deal with a 3.0 stent. He post-dilated the stent with let's say regular balloon 3.0, and then he performed the pot with a pot balloon. And what did happen, that the patient started feeling chest pain. We had a distal edge dissection. The patient moved. We lost the guide wires, and then we advanced it very quickly with a knuckle. And what did happen was that the wire went in the false lumen. So then with a SUO 03, we were able to regain the real lumen. The true lumen. We confirmed our position with the IVUS, and then we could deliver after multiple predilation that did not restore the flow. We decided to implant a smaller stent distally in order to achieve the restoration of the flow. Again, this case is just to show how this simple things like the distal optimization is something that, if is not done correctly, could lead to us to trouble, and then we need to apply techniques that we usually apply in other settings, also in a regular PCI. If you want to just have some more thoughts and more data about the pot, we know that it might happen that the balloon we use for the pot are shorter than the proximal vessel segment. And if we have to do multiple inflation, what we should do is starting proximal, going distally, because this is something that respects more the architecture of the stent without leading to a stent elongation. And when we are treating a vessel that have caliper discrepancy, some bench studies showed that maybe choosing a bigger stent and inflating it lower than nominal pressure could lead to a better stent configuration and scaffolding of the bifurcation. And once again, in this setting, a good post-dilation and the pot is mandatory. So in conclusion, even simple things could not be easy. So, you know, I'm Italian, we are very foodie. So this is just a 3-star Michelin tomato pasta, which is very simple, but people comes here from all around the world to try it. Just to say that simple things are not always easy. And both pot and dot can affect short and long-term result of our procedure. And pot balloon is really a good friend for us doing this part of our PCI. Thank you so much.
Thank you, Dr. Stefano. Thank you very much for sharing us some important information about this optimization device in our PCI. I think it's really, really important to have it in mind when we compare some different balloons to do the post dilation. Well, I surprise sometimes when I do a pot with small non-compliant balloons, 8 millimeters length balloons with a 4 or 4.5 millimeters of diameter. Sometimes there is some balloons that the diameter is bigger than the length is bigger than the diameter. Yeah, it's incredible. And pot is a quite way to do it, the pot safely. One question I would like to put to you, because when I do report using several times the pot balloon, what I think it is not so easy, because it has a very good profile in the first intention, in the first use. But if you need to do several pots, mainly with bigger balloons in left main 4, 4.5, well, it's not so easy to recross the distance. I think this is a great device. Do you think there is room to improve this rewiring or reuse of the pot balloon, Stefan?
Well, yeah, I would say that first thing, when we do the first spot, the balloon is new, but we have usually we have a wire under the stent, so we cannot achieve a very good coaxiality of our guiding catheter, and we should not push too much because we could shorten the stent, first thing. And then when we have to do the repot, usually this means that we made a kissing. So we have both the wires in the true lumen of the stents, so we could be confident to push a bit more. We could, if we do not achieve, inflate the balloon at very low atmosphere in the guiding catheter and then put it in newly in negative, and this usually helps you to achieve the positioning of the balloon. Otherwise, you could use guiding catheter extension if the proximal part of the stent above the bifurcation is long. Usually in left main, you don't have that much of room in order to advance a guiding catheter over both wires, because in this case, if you want to advance a used big balloon, usually you need a big guiding mother and child enhancer, extension.
Okay, there is other issues to improve the profile after use of balloon is doing the rewrap using the plastic cap that usually comes with the balloons, not in this particular balloon, but in every single balloon we can modify or improve and reuse the balloons. Okay, I don't know if Dr. Wenzheng has some comments about this presentation. Please go ahead.
Thank you. So I think the pot balloon is not just for the bifurcation lesion, and in some kind of lesion, just will matter because of the proximal of the vessel and the mid part of the distal part of the vessel. The difference of the diameter is very big. We also can use the pot balloon, but my question is, did you use intravascular imagery to guide you to put the pot balloon in the precise site of the stent? Because I see the slide in your point. You showed us some kind of incorrect position of the pot balloon, and you also show us the correct correct site to put the pot balloon to do the pot. So did you just use the image of the DSA, or you will use the intracoronary image to guide you to use the pot balloon? Maybe I think it will be more precise, and maybe
Well, yeah, I mean,
to
choose the size of the balloon, we use imaging in, let's say, complex PCIs or in ACS setting where you could have some vasoconstriction of the vessel in order to have a good sizing of the vessel and a good choice of the balloon. While when we do perform bifurcation, usually the positioning of the balloon is made through or small angio checks or stent magnification system in order to achieve the good position. But what sometimes happens is that the marker seems to be in the correct position, but the shoulder of the balloon, if they are big, could affect could give a carinal shift, or at least overstretch a bit the vessel when we are performing distal post dilation.
Maybe because in our center, sometimes when we do the pot, we will use the clear stent or stent boost in this function with some kind of some contrast to choose a site to put the balloon to do the pot, because sometimes we don't want any more procedures to use more devices in the coronary, just like IVUS or OCT. We may use this kind of function on DSA. I don't know if you will do that or just
we do.
angiography.
I mean, what I was saying is that if we have IVUS already open, we use IVUS. But I'm not saying that every PCI we use IVUS just to pick up the correct balloon for the pot. In that case, for sure, we use stent boost or other system to magnificate the image and better place the balloon, for sure.
Okay, thank you.
Thank you, Stefano. We will move forward and asking for Dr. Erdoğan to present this topic, effective lesion modification. What is the role of wedge and seed balloon? Please go ahead, Erdoğan.
Hello, can you see my share now?
Yes.
Hello, this is Mehmet Erdoğan. Thanks to Brosmet for this opportunity. Today I will talk about the lesion preparation in the calcified lesions. In summary, currently the calcified plaques modification preferring in some lesions, especially the first time we observed in an angiogram, a calcified plaques, we saw fluoroscopic radiopacity in the without the cardiac motion, both sides of the vessel. We observed, we said that this is a significant calcification, and then when we reviewed these calcification intravascular imaging, we see to the calcium arc, calcium length, and calcium thickness, and presence of the calcified nodules. So when we decided to these parameters, can we do, will we do to calcium modification or conventional techniques? There are some tools are for the calcium modification, such as atherectomy devices and plaque modification balloons. In generally, if we observe it an balloon uncrossable lesion, we first time choose to the atherectomy devices. On the other hand, if we observe it an balloon crossable lesions, we choose according to the imaging's features some plaque modification, balloon scoring, cutting, and IVL. There's some consensus preferred as to which is the complex calcium. If the calcium arc is above than 180 degrees and it's the intravascular imaging calcium length is above than the 5 millimeter and the OCT measurement of the calcium thickness is over than 0.5 millimeter is called as complex calcified lesion. So these are required modification techniques. For scoring balloons, I will focus on these tools. The WedgeNC is as a NC balloon. It's integrated a nitinol wire. It's a 0.011 nitinol wire integrated and single wire. And this is the NC balloon and rapid extension standard conventional design. So these wire ensure us the scoring balloon is ensure us this is a longitudinal small dissection around the vessel compared to the cutting balloon. It's especially vertical dissection to vessel wall. This is generally dissection to the longitudinal dissection to the vessel. And the second one, these features are allow as anchor to the lesion, especially calcified or osteal lesions, and highly fibrotic plaques. Compared to the other scoring balloons, the WedgeNC has longer guide wire lumen, is offer better pushability, and this eliminates guide wire twisting. This is very important, especially in the diffuse tortuous calcified lesions. This trackability is forcing for these features. In the second one, the outer hydrophilic coating and the inner silicone coating is optimized to crossability and trackability the lesions. Compared to the other scoring balloons, the WedgeNC has the lowest balloon crossing profile and the highest rated burst pressure, so we can use the safety, especially complex calcified lesions. On the other hand, the WedgeNC's NC profile is very good. When we upgrade to the ATMs, it's their non-compliant features. There are some wider range of the size to the WedgeNC 2.0 to 4.0. In summary, WedgeNC has ensured to us controlled intimal scoring, reduced elastic roll. We can control it the section for the lesion preparation, and so these features as allow us to facilitate the drug absorption period to the DCB. Now, I will present it to two cases, my clinical case. This is the first case. The 58-year-old male presented to us class 3 angina. When we performed the angiography, we see to the left main distal to LAD ostial, LAD proximal to and extending to LAD mid lesion, a calcified, highly bulky calcification, severe complex lesion. Very tight area is the LAD ostial area. Now what will we do for this patient? This is a complex PCI because this is the distal left main, ostial LAD. Here is the very thick calcium borderline of the two side of the vessel on the fluoroscopic image. And we planned for this patient IUS, but IUS catheter does not cross, so we first line preferred a small conventional balloon for the crossing the tooth, and we performed a 2.5 millimeter incision, and then we run IUS. In the IUS image, we can see to LAD ostial area. Now you can see this is the circumflex wire. Now here is nearly 270 degrees adventitial calcification. You can see in here, and this is the deep calcification. Now this is the picture. Here is the some area is the thick calcification. Here is the 270-degree calcification and the deep calcification. So we performed for the patient first line IVL therapy to focus on to deep and the circumferential calcification. We started to do LAD mid to LAD proximal and the LAD ostial area, totally 100 shots with the IVL balloon. And then we checked the IUS. Here is the LAD ostial area. Now we can see to the cracked calcium and fractured areas due to the IVL balloon. This is an acceptable result. And then we decided to these cracked and fractured calcium to separate it with the NC balloon with Wedge NC scoring balloon. And we started to the LAD mid, LAD proximal, LAD ostial, and LAD left main distal area with the 3.5 Wedge NC scoring balloon. At the mid and the proximal area of the LAD, we inflated the balloon low and the mid ATM, and LAD ostial and the LAD proximal, we inflated the balloon the higher ATMs. After the Wedge NC, we can see to the previously cracked with IVL, these calcium plaques are separated and predilated with the Wedge NC balloon. After that, we decided to do stent implantation at the proximal to mid LAD 3.0 DES. After that, we implanted left main to LAD crossover stent 4.0, and then we checked the angiogram. We show that the plaque shifting to the significant plaque shift to the circumflex ostia, and then we revire at the kissing balloon and the report. This is the final image. This is a little scoring technique. This is the final image of the LAD ostia and the distal left main. The stent expansion is adequately. So this is the first image, and this is the final result of this case. Insight from this case, the celiac and calcified lesions remains a major challenge. Acute and meticulous lesion preparation is key for optimal stent implantation and expansion. Especially left main bifurcation lesions, proper preparation in heavily calcified plaques may reduce the risk of the side branch loss. A single plaque modification device is often insufficient in these lesions. Sequential or combined use of the plaque modification techniques may be required, especially atherectomy and the others plaque modification balloons and IVL should be considered complementary tools. Insights from the Wedge NC window, the IVL has cracked and fractured calcium for this case. And the second, Wedge NC has separated cracks and dilated the lesions for optimal preparation of the lesions. This is my clinical practice. Maybe sometimes we can use a single tool for the modification of the plaque, but sometimes, especially bulky or the heavy calcified lesion, we can combine to these plaque modification tools. For this case, we use the little scoring technique. This is the second one case. This is the 61-year-old mate. This is presented to us unstable angina. Here is the LAD diagonal lesion. Especially LAD is the diffuse and the long segment. As a diagonal, the second diagonal is a great diagonal, a big diagonal. It's very important. But there are many small side branch septal and the small diagonal one. This is the long diffuse lesion, especially LAD second diagonal bifurcation area is the very significant. This is the baseline IVUS image. Here is the below than the diagonal, second diagonal. Now we can see to do some fibrotic plaques, some fibrocalcific plaques. Here is the LAD diagonal bifurcation area. Here is LAD proximal area, the concentric fibrocalcific plaques. Some areas are the deep calcification. Now we are come to the LAD proximal area. Here is circumferential adventitial calcification, and here is the proximal LAD landing zone. Now we review the detailed IVUS image. Now here is now this point LAD below than the second diagonal. Here is a eccentric fibrotic plaques, you can see. And then we run the IVUS a little proximal. Here is a non-significant fibrocalcific plaques. And then we check the, we pull back the IVUS a little below than the second diagonal. Now we can see to the non-critical fibrocalcific eccentric plaques. Here is the LAD second diagonal bifurcation area. Now you can see to the a clear second diagonal ostia. And here is the opposite side of the fibrotic plaques in the LAD. And here is the small calcification, but near the ostium of the second diagonal. And when we pull back the IVUS proximal part of the LAD, we can see to the eccentric fibrotic and some calcified lesions. Here is a dense fibrocalcific plaques. And when we check the IVUS to proximal LAD area, we can see to the circular calcification, especially adventitial calcification, and moderate lesion. And here is the small branch bifurcation. It's according to here. And we can see to the nearly circular adventitial calcification. And here is the proximal landing zone area, a semicircular non-critical calcification. Now, we planned for this patient due to the long LAD lesions, many side branches, a big second diagonal. We planned the DCB for this therapy. First time we did not choose the stent implantation due to the compromise of the side branch, and then we optimally decided to prepare the lesion with the scoring balloon with NC, with Wedge NC. Now we started to LAD mid to proximal part and the low to mid ATM 3.25 Wedge NC balloon. Now you can see to here now the angiographical image. Here is the both side of the vessel. Here is a circular calcification area. In this segment, the balloon has optimally expanded. The scoring balloon has optimally extended. On the other hand, you can see to a bit minimal indentation to mid part of the LAD. And the second part, we again predilated the higher ATM with the Wedge NC in the mid to proximal LAD parts with the 22 and 24 ATMs. After control image, we can see to the second diagonal is the patent, the LAD is the acceptable result. Maybe some small significant small septal branch ostia. After the wedge and C balloon, we run the IUs again. You can see to the scoring effect of the balloons especially in the fibrotic areas. And here is the bifurcation area. And especially in this image, you can see the scoring effect of the wedge and C. Here is. And then we decided to do DCB therapy for this patient, 3.5 30 millimeter DCB at 1 minute. This is the final image of the patient. The side branch, all side branches are the patent. The main branch stenosis are below than the 30%. This is the final IUS of the DCB. You can see to do some intima medial dissections, controlled dissection in the LAD mid and the proximal part. Here is the LAD diagonal bifurcation branch area. Now we are going to the proximal LAD. Here is some intima to medial dissections. These are a good predictor for the DCB. And then we are coming to the calcified proximal LAD area. Some small cracks and some small dissections, but especially the proximal area, the circular calcification area, the balloon's effect is reducing, but some small cracks has present. There are some increased luminal area, but now especially in the proximal calcific circular part area, the balloon's effect is reducing. Intima to medial dissection is very important if we plan to DCB, because controlled dissection is very important to DCB success. If we cannot any dissection, especially in calcified lesions, the recoil is maybe present, so it's the failure of the DCB. This is the before and after of the case, the final results. Insights from this case for wedge and C, highly effective. Wedge and C is highly effective in fibrotic and fibrocalcific lesions, but wedge and C has limited efficacy single in heavily calcified or circumferential calcified lesions. It has enables controlled dissection prior to the DCB therapy, and it's maintained an excellent crossing profile not only in the null state but also after several high ATM inflation deflation cycles due to the threefold balloon technology. So in conclusion, my impression about to do wedge and C effective lesion preparation tool in the fibrotic and fibrocalcific plaques. It's facilitates controlled and predictable plaque modification. It's enables safe preparation prior to DCB therapy. It's limited impact in heavily and circumferentially calcified lesion. In this situation, it may require adjunctive therapies, adjunctive devices such as atherectomy or IVL balloons, maintains as a favorable crossing profile even after repeated inflations, especially in bifurcation lesions. It may minimize side branch compromise and reduce stent burden. Thank you.
Thank you very much, Dr. Mehmet. Thank you for your very, very nice presentation.
Thank you.
I would like to ask you, because I used to use the wedge non-compliant balloon before RevoEdge emerged, and I must say I changed. I stopped using wedge and started using RevoEdge. What I would like to ask you is, do you find any special indication where the wedge can be used instead of RevoEdge? Any advantage? Because I think it's a great device, but I think RevoEdge has a step over the non-compliant, the wedge non-compliant balloon.
Yes.
It's a it's a
Yes,
provocative question, of course.
yes, that's a good question. Now, the WHNC is a single nitinol wire. It's integrated. It's including a single wire. When we scoring with the WHNC, especially we dissected the longitudinal and not very deep area, especially in intimal and some medial area. On the other hand, the RevoEdge has vertical dissection with the blades, and compared to these two products, when the focal calcified, heavily calcified lesion, maybe RevoEdge superior to WHNC. On the other hand, especially diffuse diseases and relatively intimate to medial calcification, scoring with the WHNC may be useful.
Thank you very much. Dr. Wenzheng, do you have any comments on this presentation?
Actually, I think maybe it's it's unfair to compare this balloon to the cutting balloon, because in our procedure nowadays, we will use the wedge balloon to instead of the compliant balloon for the pre-dilate in our daily procedure. It's much more efficient because based on the flexibility and based on the good crossing ability, we now use this kind of balloon in our daily surgery. But in that kind of maybe calcification lesion, we will choose the cutting balloon. Maybe not this balloon.
Yep.
Thank
Especially in the DCB era, we can use the first line predilatation or first line lesion preparation. We can choose the WHNC.
Yeah. Okay. Well, if no other comments, I would like to say that I couldn't be prouder to run this webinar with all of you. Congratulations to all speakers that shared their expertise, their cases. They were excellent. I think I saw some comment from the one element of Brosmet that show that there is more than 1,000 viewers and assisting this webinar. Well, it is amazing, and congratulations to Brosmet also for this capability to share and spread message and have so much people online directly right now. I am sure that this webinar brought some light not only about this device, but how to have a good use of it, a good use regarding safety and efficacy to deal with complex lesions and procedures to obtain the best acute and long-term outcomes in our patients. That is our main interest and our role is to improve the health of our patients. So I would like to thank you for all of you. Thank you for Brosmet. And we are really on time. Thank you for every guest speakers. And that's all. If any comments, please go ahead. Otherwise, I will close the session. And again, thank you very much for all.
Thank you so much.
Thank you. It's nice to meet you, everyone.
Thank you very much.
Thank you.
Bye-bye.
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 Bye-bye.